Welcome to this first plenary session of Rhythm Interventions Online 2024. We've got a great session in store. A live case from Dr. Julian Chun, Dr. Boris Schmidt, and Dr. Stefano Bordignon at CCB Markus Krankenhaus in Frankfurt, Denmark. Before we join our case center, I'm delighted to welcome our fantastic panel. We're joined by Julia Vogler from Lubeck, Serge Boveda from Toulouse. As with every session at RIO 2024, we're live. So we want you to get involved by submitting questions to us on the webpage, and we will address as many of them as we can. Without further delay, let's hand over to Boris, Julian, and Stefano in Frankfurt.
Hello, everybody. Hello, Devi. Nice to hear you and a warm welcome from Frankfurt. My name is Julian, and together with me, it's not Boris this time. We are also having a very big group, of course, and therefore this time it's Dr. Lukas Urbanek. It is Dr. Andrea Urbani, not to forget, of course, the queen from our cath lab, Silke Reda, and of course, Stefano Bordignon. And also we are very happy to have technical support from Watchman with Frank Iben. And I think we are ready to jump right into the case, and we want to show concomitant LAA closure and AF ablation procedure. And I think, Lukas, you may introduce the patient and our strategy.
Yes, our first patient is a 76-year-old patient. He has a CHA₂DS₂-VASc score of 3 and persistent AF. We did an electrocardioversion this year, but unfortunately, just after a few days, he had AFib again, and we discussed the different options together with the patient, and he didn't want to take any antiarrhythmic drugs, so we decided to perform a PVI. And furthermore, the patient is taking apixaban, but he told us several times that he's unwilling to continue taking oral anticoagulation because he has the feeling that his quality of life is not the same since taking apixaban. So we will perform a left atrial appendage closure and PVI in one procedure. And I think while most centers would start with the PFA PVI, we will start with the left atrial appendage closure. Why? We have seen some cases where even with PFA, there was a swelling of the ridge, which led to a missizing of the LAA. So we'll first do the LAA closure and then the PFA PVI. And we performed already the groin puncture, and we are ready for the transseptal puncture.
Super, Lukas. Thank you very much. And you can see it's almost like in Italy. We have many operators and one patient, but we also have 2 procedures which we want to do. And therefore, I think we jump right into our case. And if you may look onto the groin, here we have 2 venous punctures already in place. We positioned one steerable catheter inside of the coronary sinus. From the electrograms, which you may appreciate, you see white. This is electrograms from the coronary sinus, and obviously the patient is in atrial fibrillation. The patient is in deep sedation, and the previous session was also in part about sedation. We did hear some of the discussion points, and the queen, Silke Reda, she's beautifully taking care of hopefully a nice and pleasant sleep of this nice gentleman. Okay, so the 2 punctures in the groin, one for the CS, as I said. The other one, we are already parked a long sheath or a transseptal puncture sheath up in the SVC. And if we will look now and focus now on the TOE, Stefano already brought in a very nice picture of looking to the fossa. On the right, it is the cranial. On the left, it is the IVC part. And we will see our transseptal coming down in a minute. And at the same time, the fluoroscopy, we also already adjusted our table to RIO 30 degrees. And keep in mind, in our center, we have RIO 30, LAA 40 as default. We don't move the tables, and we will tell you later on why. Okay, now we remove the wire, and we go and prepare the transseptal. We flush the sheath,
Julian, can I
introduce.
just interrupt and ask the question real quick?
Oh, absolutely. Anytime.
So, the transseptal is what makes or breaks a case for LA closure, at least in my mind. So when you're combining these procedures, what's your focus? Are you trying to aim your transseptal to get a more optimal LA closure, or is it a midway approach between PFA and LA closure?
Absolutely. It's a very good question. And we wanted to show it and discuss this point. This is why we did wait for it. In an ideal scenario, of course, the transseptal would serve perfectly for both modalities. However, we know that for transseptal, for let's say, typical RF ablation or cryoballoon ablation, posterior inferior is probably the desired position, whereas for LA closure, sometimes a little more anterior may also help. So therefore, in the middle central, I think is from practical standpoint, a good compromise serving both needs. We will try to be not too high, but mid-low, that would be, I think, acceptable. And this is where we are, what we do now. Now you can see the fluoro. We pull down the sheath, pull down, pull down, pull down. There was some tiny little jump, not too big of a jump. Here, you see we're in the middle section in this 112 degrees view. We have a beautiful tenting here. In the fluoro, you see also the consensual movement. I think it is acceptable. We can come down maybe 1 millimeter. Okay. Yeah, I do. Yeah.
Steve, yes. Yeah, thank you.
Yeah, and okay, perfect. Now, Stefano, why don't you go to 40, 45? Yep. Okay. You see this tenting here, and it's pretty posterior if I look at this. Therefore, I allow myself to be a little more anterior, like this. Again, counterclock movement is bringing me a little more anterior. Fluoro looks a little more anterior. I think it's acceptable. I puncture. Needle is over, and we have a pressure. Okay, we have a pressure, and we see here the pressure curve indicating the correct position. Now, I would like to take the wire. We do it very, very safe, of course. And you see some blood is coming out. We introduce the wire, and then we are already pointing towards the appendage, but I like to park the wire in the left upper. And here we can easily cross now with the transseptal over to the left atrium. Here we are. Remove the wire and flush the sheath. Devi, we already deployed heparin before the procedure. This gentleman has a body weight of, I think, of roughly 80 kilograms. And we deployed or did administer 10,000 units of heparin. Now we flush our sheath. Thank you very much. Mrs. Reda is ready to do this.
Getting its sheet ready. I just want to bring in Julia and Serge. What are your thoughts on concomitant? Do you do the appendage closure first or ablation first? Julia, I'll start with you.
Lucas. Okay.
So we actually rarely perform concomitant closure due to our reimbursement issues. But when we performed it, we did PVI at first. That would have been my question as well. And I'm surprised that they went for left atrial appendage occlusion first. I was also about to ask if there was any pre-procedural imaging, because you nicely mentioned, Debbie, that the transseptal may be crucial, and there might be some anatomies where we wanted a more anterior puncture for the left atrial appendage closure. So I was just wondering, do you perform any pre-procedural imaging, or do you skip it? For the guys in Frankfurt.
Asking me, or are you asking Debbie?
I'm asking you if you perform, if you would go in, if you perform concomitant closure. Do you think it might be helpful to have a pre-procedural TOE or CT for complex anatomies?
Yeah, of course, it's a very good point and very valid question. The more you know, of course, the better you can plan a procedure, very much in generally speaking. And so therefore, it may make sense to have a pretty good idea about a patient's pre-existing individual anatomy. In this case, however, we are in Germans. We are very pragmatic. We did not do, and we do not do so far, routine additional imaging. It's basically as this patient as he came on the table with all the imaging we have here. So we feel it could be nice to have more information, but in real life, we believe it works typically also very good without too much of an additional imaging. If you have, let's say, a very structured workflow and idea what to do. But maybe I will be proven wrong in a minute once we enter or engage the appendage. So now I did one round. Take it off. Yeah, thanks. I did one round of selective angiograms. Now we will shoot our thank you, our left atrial appendage. So we were switched for a piggy. And here we go. Stefan, bin ich drin?
I don't see you in the... Yeah.
Ich denke, yeah. So
Yeah,
we
now
see
it's-
in
yeah.
the TOE, we see some little bubbles. And here we have the pigtail
There.
sitting in the appendage. And so here we go. Okay, here we go. This is, the appendage in the 30. Now cranial. And then caudal, please. 30-15, super. So you see,
Your pigtail is still quite proximal.
yeah, it is somewhat at this rougher,
Yeah.
stuck at this rougher part. We will see it now with a 15 cranial view. Okay, here we see it. Okay, we go down to 20 caudal. And maybe we can also focus on the TOE, Stefano. And I'm sure you already did a couple of measures for the landing zone, etc. Okay, here we go. So we have a lobe, which is running in an anterior direction here in the caudal view. And there's a second lobe, which is going a little more than anterior. Does it match to what you see in the TOE?
Yes, I have to
Dr.
say
Bo?
that we used to represent the appendage in at least 3 planes. We start with the 30 degrees, where you can see usually something like the cranial view from the angiograms. And you can see here that we have an appendage. There's quite a long landing zone. Here we have some place to park our device. The ostium is quite big, but I think that our landing zone will be something like that, or maybe something like that. So I think that we are... the landing zone is here 18 millimeter. When I move to the second view, is the 90 degrees view. The 90 degrees view on the right side is cranial, on the left side is caudal. You can see here that once again you see how long is the landing zone in this appendage, and we can measure once again here the landing zone. You see here it's fairly smaller. I think that we will have a landing zone something like that. It's 15-16 millimeter. But I think that we could accept here some kind of a shoulder also to come proximal here and to occlude this proximal part of the appendage. And the 135 degrees is the fourth view that we're using. You see how eccentric is this? And here on the left side is infero-posterior. And in the infero-posterior part of the appendage, you can see that then suddenly the neck, the landing zones look a little bit bigger. I think that we'll come here to 20, 21. And so it's so I think that the landing zone here is quite eccentric, and I have so 15 millimeter per 21 millimeter, and in the 145 degrees. I'm curious what you measured, Youngie.
Yeah, pretty similar to what you were saying. That we have an eccentric anatomy for sure. We are sitting with our. You need to know. Stefano cannot see the fluoro. We are sitting with our pigtail in this early lobe, and we do not have a very nice view, maybe here, from the deeper part of it. Despite of some manipulation, we do not get too deep with our pigtail, but we have numbers of 17 to 18 something, was it, right?
18.
Maybe you just show it again.
The numbers?
Oh, yeah. Measure here one time.
Yes.
So the question, of course, now will be what size shall we use in order to occlude this not too easy anatomy? And I was maybe proven wrong, Devi. This is definitely not an easy appendage to select. And therefore, with the Watchman, we have, of course, different options, if you want. We could think of going maybe 24 millimeter, maybe bigger, 27 millimeter. So what I like to do, I always engage an open discussion on what is probably the best sizing. And Dr. Bo, from your views, and from your imaging,
since it is,
what would you recommend?
It is eccentric, but the maximum diameter that I measured was 20-21, and so I think that the 20 would be too small. On the other side, the 27 would be too big, so I think that I would decide for a 24, and I would accept a little bit of shoulder in this plane, so that even the proximal lobe there is covered with the device.
I agree. I think even though we know that the flex is very flexible, 27 may be too big, and therefore 24 looks, at least for us, as probably the best version. And unless the distinguished panels may have different ideas, we would move on with the 27 device.
Okay. No, Julian.
Or device.
24, okay.
24.
Right. So
24.
Let me just ask you a question. I'm going to actually pose it to Serge. So, the patient is in AFib, and we're putting in a device, and I'm assuming Julian's planning to leave the lab in sinus rhythm. So I always wonder, there's edema that we talk about. We also have to wonder about the LA contractility after, and does that change, how the radial forces apply with this device once you implant it and leave it? So, like Julia, I always do the appendage closure after the ablation. And I understand, about the edema part, but, we do pre-screening and so we kind of plan according to the sizing before. So what are your thoughts? I mean, I think 24 is, in my mind, I think it's a great size. We're probably going to run a 15% compression, maybe. I have always kind of stayed in the 20-25% compression with the flex, just because I feel like it accommodates better. Just what are your thoughts on the 24 versus 27 in this case?
Yeah, thank you, Devi. First, I want to say hello to my friend Julian and the team in Frankfurt. Hi, this is Serge from Toulouse. I agree. I fully agree with the team in Frankfurt that the 24 seems to be the more logical choice in this case, because in addition, I have the feeling, even if I'm not in the lab, but from here, I have the feeling that the appendage is quite short, and I am afraid that 27 maybe would go a little bit too much out of the the appendage. So I really agree that the 24. This was my choice also. So I am completely with the team in Frankfurt. 24.
Hi, Serge.
Thank you, Serge.
We totally agree. I think that there is this RAF. You can see it in the 135 degrees. There is a proximal, some kind of separation between an inferior lobe and a superior lobe that probably will impede to use the longer lobe as the landing zone. And so with the 27, we probably would have a too long shoulder of the device. And this was another reason why we decided to go for 24.
Yeah, I fully agree. I think that the two lobes make it difficult for the 27. I agree.
Yeah.
I do want to encourage our audience to make sure that you send us questions through the feature, and we will kind of keep it going. And please address the questions to either the operators or the panelists.
So I also have one question. Yeah. So the patient is an AFib. So when are you going? So and you're also going to do PVI. So when are you going to cardiovert the patient? So if he gets AFib again during PVI, so are you afraid of dislodgement of the LAA occluder if you implant that first? Or so what's your strategy?
Yeah, that's a very also good point. Of course, from emotional standpoint, cardioversion, you may feel a little afraid of running into some dislodgement. However, what we typically would do, we will tuck the device once you have implanted it, and while it was still plugged, we can also cardiovert. So, I mean, we will do a PVI, perfect, thank you. A PVI procedure in the patient, and yeah, we will cardiovert once it's still hooked to the device. Now, we introduced the device, and Andrea prepared the device. You see here, now we are sitting right in front of the appendage. And why don't we show the review mode and store the cranial view 15. This is the vein. Yeah, this is still the vein. This is still the vein. Yeah. Yes. Thank you. Perfect. So here we have in the review mode, we have the RIO in the fluoro, and we have the 40 degrees now, corresponding 40 degrees in the TOE. You see the little ball of the device. Maybe we can do our colleagues a favor and show a little better what we do. So we play a little bit with the machine and the resolution. So now we come up with a little ball, as you can see here. And now we advance it, okay? We have entered, thank you, Steph.
Okay.
The appendage.
I go in the one.
We have entered the appendage, and we will now switch to 120. And remember, there was this roughy thing, which we see here. We are right at it. Do you agree, Stefano?
Yeah, yeah.
But we are right here at it. And again, we have not changed the table's position. And we are here with our ball configuration, pretty much where the initial position was from our pigtail. Just one thing, we use the Watchman sheath, which is braided. And this hopefully allows us also for a more stable, let's say, manipulation. It is, yeah, hopefully a nice, let's say, additional feature from this new sheath. Okay, here, if I do clock rotation, you see, I move a little more central and in a little more anterior position. And now I ask Stefano, what do you think from this position here, according to the 120 view?
So you are behind the circumflex. You are in the right part, in my opinion, of the appendage, in the right lobe. And so you're deep enough. I would also change to the other view to see how deep you are. And you see here, you are completely behind the circumflex. Yeah. I think that you might try to deploy it. I hope that this RAF is not pushing you outside. So, but I would try to go for this position.
Do it, and now we focus on the live fluoro, and I deliver the device, as you can see here. Okay, now the device has come off. And it looks a little deep.
It's a little bit too deep.
Yeah, it looks a little deep.
Yeah.
And I think what we do is then we do a recapture, keep a little of this torque, and I come back a little bit. How about here? I think we are right in this.
But be careful because it tilted.
But
toward the other lobe. Now.
yeah.
Can we continue to see the TE as well?
Oh,
Yeah.
sorry.
Thank you.
Zeig nochmal das TOE in der 45, Dr. Bo.
Okay, sorry. So this is the actual position. Okay, you see that in 55 we are exactly at the landing zone that we planned here. When we go to the 90 degrees, we also have this small shoulder that we wanted to. We were looking for that, okay, because we wanted to have in the 90 degrees this small shoulder to be sure that on the other plane we were closing the other lobe there posterior, and you can see here that we have a small leakage here, small part of the ostium that is not covered. So the second proximal lobe is not completely covered, and I can measure here, and so you can measure it's 3 millimeters leakage in the inferior part with in this proximal lobe.
So what we do is we will cross-check this with the angiogram, and I will shoot one more time with contrast, with dye. Here we go. So here we have the dye injection. I think the distal section is nicely covered, but in the 120, I agree, there's still some leakage. So, okay. We go back again. The recapture, and we try to come up a little higher. A little higher. Fluoro. Yeah. Kannst du nochmal die 100? Can you show me one more time the 120?
Yeah. Okay.
Yeah, we are still facing the similar issue we had with the pigtail. Here.
You have to come more proximal, in my opinion.
Come back again.
Yeah.
Kannst du mal, can you do some dye? Can you do some dye? Thank you. Thank you.
Julian, what curvature sheet are you using? Is it a single curve or a double curve?
It's a double curve.
Double curve, okay.
It's a double curved sheath. So we did deploy a little dye here in this caudal view. And I think the position is not too bad.
Yep.
So you're behind the circumflex, so
We do another deployment.
No.
The shoulder is bigger now, huh?
Yeah.
That's definitely not good.
You're more proximal.
Again.
Yeah.
I do recapture. And we are deeper in. Yeah, now we're again here. Can you show one more time the 120, Dr. Bo?
Yeah, sorry. You are now in the inferior lobe. You are pointing toward the inferior lobe, not more the main lobe. Yeah, now you are once again in the main
we're
lobe.
in the main lobe again.
Yeah.
You saw really also the move. How deep are we now with this one?
I have to change my view to show you how deep you are. You are proximal, but
I go a little more deeper. I do a little counterclock rotation. And I think maybe here. What do you think?
Okay, I'll look once again in the other plane. I think that here we are too proximal. Yeah, here.
I go a little more deep even, like this. Got it. Okay, here, definitely more deep.
Yeah, you're deeper, you're in the main lobe. This is very similar to the first position.
Come back, my dear, my friend. Okay, let's check this one, please. Gehen wir mal auf 45.
Okay. On 45, we have quite a deep position. If we go to 90, we don't have this shoulder anymore as before. And the 130, This bridge between the two lobes.
I think the second position we had was the best so far.
Yeah.
This is not good enough. So
Julian, would you try a full recapture so the anchors become disengaged so you have a little more better motion into the appendage?
How about here?
That looks
How about this one here, Stefano? I'm sorry.
Okay, now you are much proximal.
Yeah. Definitely much proximal.
You have a bigger shoulder on that plane.
I do recapture again. I did not like this, my dear.
Okay.
Yeah.
I think one thing that you're doing so well is, I mean, if it's not a good position, you're recapturing right away because this is such an occlusive device that once you put the device in and if you sit on it, sometimes you develop thrombus behind the device. So Julian's showing very well how the position's not good. He's recapturing and kind of optimizing the implant on a real time.
Okay. Mach mal 45. Ich glaube, das ist fast
okay. Now it's our
second
position once again. Yeah, with the small shoulder.
So Julian, one thing I'm seeing is there's such a big core wire bias, right? So the question is when you release it, is it going to just tilt down and help you give some coverage on that posterior lobe? Just something to keep in mind.
That's a very good aspect on this. I think it's not too bad. Maybe 120. So what we do is we do another die. Stefano, kannst du nochmal auf 45 so gehen?
Yep.
Und wir machen noch ein bisschen Kontrast. Komm. Ja. Hätten wir denn das 31er Device auch schon vorbereitet gleich? Nein, ich meinte für unsere Ablation später. Ja. Müssen wir noch gucken, wie viel Zeit wir haben.
Lukas und Andreas.
Gib mir nochmal.
Prepare the device.
Okay, we have still some time. That's good. So here is the shot in the caudal.
Julian, what about doing a smaller tech test here in order to maybe close the little gap that you have in the posterior?
That's a good thing. I tack now. Thank you, Serge. Here we go.
Yeah.
Restore it.
Maybe try again.
At least it is super stable. It is super stable.
It is very stable.
This is for sure. Yeah.
Sometimes when you have a small
with the tack test, Serge, the device came back.
Yeah, so we keep discussing here, of course, back and forth, and we have the impression that from let's say also here in the TOE, would accept a shoulder. We have from the angiogram, we replay it again. Mm-hmm. We have a very good occlusion and a good seal, and we cross-check here. Gehen wir wieder auf eine andere Ebene nochmal zurück.
It looks better, huh?
Okay. Yeah, it definitely does. I mean, if you had more depth, obviously you could use a bigger device, but you're limited by depth. So I think this is the best the 24 is going to be able to give you because you're limited by the pectinate too.
I agree. I think the 27 here would be possible to place.
And the 27 may be too big. And
Yeah.
I think this is
The appendage is
an
too short.
acceptable position, also again based on our angiographic observations. But yeah, we had it and we spoke about it in the very beginning. Sometimes it can be very challenging and difficult. So then I would say we do a cardioversion.
So I think another thing about the bigger device would be you are going to get some edema with the ablation. So I think you have to think about that as well. And so I think 24 seems like the right choice for sure.
Agree.
Shock. All right. So we cardioverted the patient. Now sinus rhythm. It's still attached to the cable. What I will do, I will tug it one more time in 45, and you see it in the fluoro and the TOA and fluoro as well. Keep it here. Okay, it is very, very stable. And I think we will release now the cable. Here we go. Here we go. So the device is ready, and we can bring out the device. And now we are preparing the ablation part of it. Andrea?
Yeah.
Now I need the wire, please.
Yeah. I come with the wire.
Yep. Thank you. Good. So, a little more than I thought, honestly. Is your vein probably, Stefano?
Question from the audience, and I'll let the panelists jump in as well, about what your usual indications for a concomitant procedure are, especially with the stage of reimbursements in Germany and in Europe.
In France, at least, it's very limited because we don't have reimbursement. So the indications are very, very few. I have to be honest with you, and most patients that we have, we did a concomitant were for the option trial. So I think that in a routine basis in my country, it's very difficult to propose this solution, which I believe that probably in the future, because we know about the recent results, will be a very good alternative for the patient. But for the moment, it's not viable economically, I would say.
The same for us.
It's definitely true. Yeah. Right. So it's definitely changed in the US. You know, we just had reimbursement come through for concomitant procedure. Obviously, still in the indicated population, you know, the patient's not tolerating oral anticoagulation. But it was, you brought up the option trial, and I think we definitely saw some interesting results in option, very positive results in option in my mind, at least from a long-term bleeding risk standpoint. And with the non-inferiority in stroke and systemic embolism, I think, you know, we'll have to wait and see what Champion and Catalyst show, but definitely some positive results. Good for patients, more options for patients, right?
Absolutely. I think that
I also have one question regarding the device. For you in Frankfurt, would you also consider a disc device when you do concomitant procedures, when you do LAA occlusion first? I mean, just do you think it would have an effect on your PVI if the disc covers the ridge in any way?
Yeah. Also very good question. And as you all already stated, in Europe, we face the problem. We don't have the systematics to do it, let's say, on a greater scale. However, there's some experience, of course, of ablation, especially using FARAPULSE, for instance, in the context of an LAA closure device. And we know if there was, for instance, a large disc reaching out towards the PVs and you touch the ridge with the device, you may create a short circuit type of thing, and therefore will not be able to deliver the energy. So there's therefore a known interaction, I feel, with the Watchman, of course, you have some at least advantage when it comes to that, let's say, issue. Now, here, maybe we show it again. We have the device. Of course, today, many people already have seen the FARAPULSE device. It is an over-the-wire device. We know it comes in two sizes, 35 and 31 millimeter. And here we have selected the 31 millimeter device. It's, as I said, pentaspline. It is equipped with electrodes, and electrode number 3 is able to record bipolar electrogram. So we will use it also to assess isolation, yes or no. And we can change seamlessly, Andrea, from the flower seamlessly into something smaller, which we call the basket. Go back to the basket. Yeah, and then even smaller, which we call the olive. Maybe you can see it here. And this is the protocol we will use now. Okay, so we stretch, we checked for integrity of the device. We introduce the catheter into the FARA sheath. And here,
Julian, you don't need me anymore for the TUE, or do you want?
oh no, thank you, Stefano.
Okay, because
Maybe you do a couple of nice last pictures.
I already
Oh,
the
did you
picture
do?
of
Okay.
the
Yeah,
of
all
the
right.
ridge,
Here, this is the last TOE pictures. Okay, perfect. Maybe, yeah, okay, that's wonderful. In the meantime, I aspirate my sheath a couple of times to ensure no air engagement while changing. And I did this. I am happy. Now we do test one more time, also for an ACT. My favorite ACT here would be 351. So let's see what we can get. And all right, so thank you, Dr. Bo. Here now the wire will come up. You see in the upper panel the reference from the left upper vein in the RIO.
We're in the catalog view. Yeah.
And we need to go back to RIO 30. Here we go. The wire is it? Yeah, it's running easily into this vein, and we have the roadmap. Perfect. Now you keep it there. I slowly advance the device. I show it to you, and now the sheath is pulled back, so we have alignment of the distal marker from the sheath and the proximal marker from the device. We open up the device and we engage towards the left upper vein. Now, looking at the electrograms, you see the EKG. We have the signals from the coronary sinus, and we would be able to pace in case of need. Can we check that for 1 second? Einmal bitte stimulieren.
Yes, we are okay.
Wonderful. Thank you. Maybe a little faster later on. Oh, it's okay. We captured.
Yeah.
Now, I cross-check again with Silke Reda. Sedation, wie viel Fentanyl haben wir? 75. Und wie viel Propo? 45. Okay, wow, okay. So then you see it's a pretty small vein. Here we are sitting right at the ostial side of the vein here, and we like to start off with the position we call the basket. And once I push my catheter in my sheath, you see interactions of the spline with the tissue, indicating tissue contact, tissue to catheter contact. And I think it's acceptable. We like it. We start. I think we have 10 minutes left.
Maybe not.
Okay, wonderful. And F8, maybe you can show before and after.
One more.
Yeah, thank you.
So a rotation.
So we rotate one more time. Yeah. Again, keeping the push.
If I understood well, Julian, you are not providing atropine systematically to the patient before starting, huh?
One more.
Yeah, we use it in female patients, and older male patients, we always are a little, let's say, not reluctant, but we always, whenever there's a past history of any prostate problem, peeing, basically, we would withhold
Only.
Makes sense.
the atropine, and this is why we did it here. Now, we moved into a little smaller configuration. As you can see here, this is what we call our Frankfurt Italian olive. And you see here, the olive is not flipping very deep inside. It is just really in the ostial side of this left upper pulmonary vein. So we have now a total of 6 applications. we go back into the flower, as you can see here. And now again, I push my sheath, and now comes the thing. Yep.
Yeah.
We check the second angulation, the 30. Yeah. Here, this is better, a little better. You see again the interactions with the big flower to the tissue, and also change of the local electrograms, which is definitely, of course, more antral positioned. Yeah, thank you. We replay it, we stored what we did, and we do again another set of 4 applications. And you see here again the big and strong contact. Now we rotate by 30-60 degrees, yes?
Yes.
And we do deliver
2 more.
2 more. Then in total we have 10. And if I look to the watch, we have 7 minutes left, I think. Okay, so we will see how far we get. Thank you. Why don't you show the roadmap for the left lower? Thank you. Yep. Here we have the left lower. You see it here. And now come back with my sheath, rotate the sheath, and do a little counterclock rotation. Yeah, and we will dive into this left lower vein. And now, again, I push sheath and catheter, again, flipping back of the petals, indicating nice contact. Cross-checking in the RIO. In the RIO, we feel it is important to rotate clockwise, as I do here, improving contact to the anterior aspect. Please go. Yes.
7 minutes is more than enough for you, Julian, huh? For 3 veins.
Well, you get to see really well how you're further away from the Watchman too. Even though they implanted the device first, it looks like the ridge is keeping them away from the device. So I think you brought a good point, Julian, that I think you have to be careful about the interaction, because sometimes you'll actually see the noise on the signals telling you that you're close. You know, sometimes we'll bring patients back who've had a appendage closure device, and that's one thing that we tend to look for. But I think those are some great tips for fluoroscopy, to look for contact, because contact, we now know that contact is important. And seeing those petals diverge is important. I know I always bring it up, Julian. You know, we get spoiled in the US with ice, so we end up using ice for contact. So it always fascinates me when I see you use fluoro and so expertly manipulate the catheter in there. Julia, what are your thoughts on contact assessment, fluoro versus ice, and the data on that?
Patient.
You mean, sorry, I got Julian. So, well, I think we don't have ice as well. So we are using, actually, we would love to have it, because I saw your very nice images at the HRS, but we are actually using the same ways to help us with the fluoroscopy to see if there is contact, because we don't have ice as well, but I think it would be very nice to have ice. Yes.
I think for us, sorry, Serge, go ahead.
No, sorry. No, I just wanted to say that in all Europe, we are doing the same method, because we cannot use ice, at least on routine basis. So I think that it's a matter of being trained with this in this way. But obviously, ice has big advantages, especially when you are doing a concomitant, because you can also assess the deployment of the left appendage occluder. So I think that in this case, even for a concomitant, it would be even more useful than for a regular AFib ablation. But I agree. Unfortunately, we don't have it.
I was just wondering, Devi, how are your results with your LAA occluders? I think you in the US can perform concomitant ablation and LAA occlusion. So I think in the option trial, they say like 80% perfect seal, but it's less than the pinnacle. So what are your experience? Because I mean, if you do both, you have to you have some trade-offs. So what are your experience about that?
Devi, Julia, and Serge, may I just very briefly draw your attention to what we did right now. We moved from the left lower to the right inferior vein. Sometimes this is felt to be the difficult vein to reach. The way we do it is we use the flower mode and move over in the flower mode with the wire pulled back, of course, and then just do clock rotation and adjust the height based on our previous angiogram, and then we advance the wire. And here, it is stored. We also had prolapsing of petals inside, and this we compensated by doing some rotations. And now we have a beautiful signal in the EKG from the right inferior vein, and we will ablate. And now, I'm sorry to interrupt. You can continue with your discussion, of course.
And this is very nice, Julian. Thank you. Very nice.
I mean, the fact that Julian's already on his third vein and we're like 3 minutes or 4 minutes into this case is incredible. But you know, he's also a very masterful operator there. So, I mean, as Julian goes to the pulmonary vein, I'll come back and answer that question, Julia. So I think, you know, that was one of the most interesting things out of option for me is, you know, I think seal is very, very important. We know that leaks matter, right? So when I look at option, I think that was the first time we were starting to do concomitant procedures. And I think there's a learning curve to it. I mean, Julian went through a process of doing the appendage closure first. You know, we're doing ablation first. There's question about pre-procedure planning. How do you size the device appropriately? So I think those are things that we will learn as we understand more about the pros and cons of concomitant learning curve, a lot of those things, right? And then whether you use TEE or whether you use ICE, because we also have seen some data on ICE usage. Do you use 2D ICE? Do you use 4D ICE? So I think we do get a little bit spoiled in the US with all the technology. So more to come on that. So I'm hoping that with the concomitant DRG approval, we'll have more data because more centers are going to be able to do it. Option had 40% concomitant procedures for that matter. So, but definitely we have to be better. I agree that we have to have a better complete seal if we are going to be offering this as first-line therapy, for sure. So it's a great point. Now, you know, for us, the whole use of ICE was mainly to reduce fluoroscopy, not really aid in concomitant procedures. You know, we don't use fluoroscopy for any of our PFA procedures, but we use fluoroscopy for our appendage closure. So it just, you know, it's a mix and match kind of deal. Serge, you did option. What are your thoughts on the whole concomitant and 80% feel with
we were mostly the cases we did contribute to option. First of all, congratulations to the great manuscript, all the contributing authors, of course. We performed typically first ablation and then occlusion of the appendage. This is the typical sequence. I think it is a great option from a patient's perspective, of course, as you said. And what was striking in option to me was the low rate of strokes in both arms after AF ablation. I think this is something which also deserves a little more attention. But now we moved, Devi, into the right upper, and here again, you saw this flipping around maneuver, and we ablate, and we are sitting right here at this right upper pulmonary vein. In the upper panel, we have our review mode of this takeoff of this right upper vein. So no more signals, at least here, right now, detectable. And we do one more rotation like this. There's one, a little prolapsing. Yeah, here, this I like.
Yes.
So, Julian, and I know we're kind of running out of time, but we do want to give you a few more minutes, maybe 2 minutes to kind of show us the basket position in the right superior as well.
One more.
How many lesions are you doing on an average per vein?
Basket.
So we do 10. 8 as the traditional recipe, and then we do deploy 2 additional in a little smaller configuration. We call it the Frankfurt Italian olive. We did this because we felt within the safety margin of not doing, of course, too many applications and avoiding and knowing there's no risk of PV stenosis at this point in time, we felt it is safe to go a little not very distal, but a little in that ostial section. And this is what we do. And in our experience, in our center's experience, the durability rate in patients who come back is better. And this is why we continue. 40 applications, a standard protocol in 4 veins, 10 shots per vein.
I mean, Julian, you've done a great job showing us a fantastic case of concomitant LAA closure, and especially in the challenging anatomy of LAA with the PVI done right after with PFA. Any final thoughts from my expert panelists, Julia?
I actually have to congratulate them. Perfect live case and stayed in time. And we saw LAA occlusion and PVI and on time. Congrats.
Serge?
Yeah, Julian, really a very great job, guys in Frankfurt. Congratulations. Really on time, perfect. And it was indeed, as Devi was saying, a very difficult anatomy, I think, for the left appendage. So you did it really great. So bravo. Nothing else to say. And thank you.
Well, thank you, Julian and Stefano and your entire team and the queen that managed that anesthesia. It was impeccable.
Yeah.
So thank you to the team in Frankfurt. Thank you to Julia and Serge for joining us today. We will conclude the session. Up next, we have a symposium entitled AF Care Pathway in 2025, from ablation to stroke prevention. So stay with us.